Good morning, everyone. My name is Mohammad Zatmar Khan. I'm a third-year resident at Central Michigan University, and today I'm going to be talking about a case which focuses on the minimization of biliary fluid loss in patients who've had biliary drains placed. So I'll start my talk by briefly mentioning about the types of biliary drainage catheters. They're usually referred to as percutaneous transhepatic biliary drainage catheters, or PTBD. Both of these drainage catheters are placed percutaneously. We have two types of drainage catheters: external drainage catheters, which, as is evident from the name, drains bile externally, and internal external drainage catheters, which drain bile both internally through the ampulla of Vater into the duodenum and externally outside the body cavity. So internal external drainage catheters are better because they minimize the biliary fluid loss, and as we all know that biliary fluid is rich in sodium, so it also prevents a common complication of hypovolemic hyponatremia. So our case here is a 70 years old female who was recently diagnosed with hepatocellular carcinoma because she presented with a portohepatous mass, and she had symptoms that she had jaundice, and she was found to be confused and fatigued. She had placement of an external PTBD catheter at one of the outlying facilities. She was also noted to have greater than 1 liters per day of biliary output through her external drainage catheter. When she presented to our facility, she was found to be confused and fatigued. Her vitals were taken, and she was found to be hypotensive with a blood pressure of 100 over 60 millimeters mercury, and her sodium was low at 127. Bilirubin was elevated 2.5 milligrams per deciliter. Most of it was the direct fraction because it was obstructive jaundice. Our liver enzymes were elevated, especially the alkaline phosphatase, because the biliary ducts were involved. So she was admitted under the impression of malignant hyperbilirubinemia secondary to biliary obstruction, and she was admitted onto the floors. Interventional radiology was consulted, who underwent for the exchange of the external drainage catheter. So they exchanged the external drainage catheter and replaced it with an internal external drain. So they did a post-procedure cholangiogram, which is a common technique which is usually done after the placement of a biliary drainage catheter. So as you can see, this is the biliary drainage catheter, which is entering the left hepatic duct percutaneously, and you can see the right hepatic duct here, and this is the confluence of the two ducts, and the lady's mass would have been most likely around somewhere here, and you can see the distal end of the drainage catheter is passing past the obstruction, and it is draining the bile through the ampulla of Vater into the duodenum. So you can see the spillage of the dye into the duodenum here. So she got better after a few days, and her sodium levels improved. She kind of got back to her baseline, and later on she was discharged with instructions to follow up with oncologist, as she had this hepatocellular carcinoma, which was recently diagnosed. So it was a really interesting case because it gave us a thought about how to prevent and minimize the biliary fluid losses. And so I would say that, malignant obstructive jaundice is usually secondary to the hepatocellular carcinoma. It can also arise secondary to pancreas head neoplasm, or it can be secondary to cholangiocarcinoma. Surgical resection remains the mainstay of treatment. However, in most of the candidates, presentation is at advanced stage where the tumors are unresectable. So palliative interventions such as the drainage catheters are commonly employed. Experimental studies have shown that the internal biliary drainage catheters are superior to external biliary drainage catheters as they preserve the enterohepatic circulation, as I have talked about it earlier. So bile, as we all know, is a fluid which is rich in sodium. So excessive loss of biliary fluid, as in our case, can result in hypovolemic hyponatremia, and we can see the complications resulting from hyponatremia, which include confusion and other CNS-related complications. So percutaneous transhepatic biliary drainage is a widely used, safe, and effective palliative procedure for malignant biliary obstructions. With increased expertise, better training, and instrumentation, the success rate nowadays approach for 90 to 95%. It is also a feasible, safe, and effective procedure for the treatment of post-surgical biliary leaks. However, every procedure is accompanied by complications of its own, as is with the drainage catheters. So I would just wrap up my talk by just mentioning that, whenever patients present to you at an advanced stage and with a diagnosis of hepatocellular carcinoma, and they present with malignant biliary obstruction, we would always aim for a palliative approach by placing a drainage catheter which prevents the complications of fluid and electrolyte losses. So the best type of catheter that we can place in patients like this is an internal external drainage catheter, which preserves the interhepatic circulation and minimizes the biliary fluid and electrolyte losses. I thank you all and have a nice day.